So good morning, everyone. Welcome again to the Data at Breakfast. My name is Francesco Petruccione, and I'm sometimes responsible for you waking up early in the morning to attend this meeting. I wanted, before I introduce the speakers, to briefly apologize that the Data at Breakfast was a little bit absent the last couple of weeks, but I guess everybody is very busy and it's quite challenging times for many obvious reasons. So this morning, we are really very, very happy and grateful to have again with us Professor Tulio de Oliveira and Dr. Richard Lessells from the CRISP unit at UKZN. And they kindly agreed to give us an update on the situation of COVID-19 in South Africa and possibly in the rest of the world. Yeah? So I don't think I have to spend much more time introducing the two speakers, because you all know that they've been central in fighting the COVID pandemic in South Africa and in making some of the crucial decisions that paved the trajectory of fighting COVID in the country. So without wasting your time anymore, Tulio and Richard, thank you so much. I know how precious your time is in these crazy times of ours. So we are all very, very grateful that you made the effort to be with us again this morning. So please, you're most welcome to start your presentation. And as usual, please make use of the Q&A facility to ask your questions, and we will forward them to Richard and Tulio. So Richard and Tulio, thank you so much.
Okay, good morning, everyone. Yeah, and thank you again, Francesco, to invite Richard and I for this breakfast. Yeah, as you know, we are old friends of the breakfast. Yeah, and it's always a pleasure to come back. Yeah. So today, what we will do for you, yeah, is going to be an update. To be honest, it's very timely, this update, because a lot happened in the last week. So what we're going to be talking a lot, it's about this new variant that has emerged in South Africa called the Delta variant, and how it has spreading very, very quick. And now we are quite confident that's responsible to most of the infections in the explosive third wave. Yeah. So Richard and I today, we are talking on behalf of the Network for Genomic Surveillance in South Africa, which the website's below. And this is a network that's funded by the Department of Science and Innovation and involve many of the universities and public health facilities in the country, such as the NHLS, the UCT, Stellenbosch, University of the Free State, University of KwaZulu-Natal, Wits, University of Pretoria, and the NICD. So this is truly a team effort. Yeah. So if you go to the next slide, one thing that we always like to start it's where we are in the pandemic. Yeah. Of course, most of you will be aware this graphic is presented every day by the media. Yeah. And just to highlight you there, in the x-axis, we have the date. In the y-axis, we have the daily cases and weekly excess deaths. And then what you're going to notice, it is another variable that we always like to present, that's the reproductive number of infections. Yeah. Why that? This is a variable that is in red. Yeah. And as you're going to notice, each time that before a big wave arrives, that's going to rise, and it's going to rise above 1. And what we are at the moment in South Africa, we have been for a number of weeks, around 6 weeks, with a reproductive number higher than 1. And what it means that the epidemic entered exponential growth phase. And this exponential growth will likely to continue unless more restrictions are put in place, what just happened. Yeah. If you go to the next slide, what we just to highlight that it is how do we do this genomic surveillance? Yeah. So what we have done, we have set up like 8 laboratories across the country. Yeah. and they are geographically distributed from Johannesburg and Pretoria with the NICD, University of Pretoria and WITS, here in Durban with ourselves at University of KwaZulu-Natal, and then in the Free State with the University of the Free State, and then in Cape Town and Stellenbosch, yeah. And what we do between these laboratories, yeah, is to try to do continuous genomic surveillance at close where the samples are collected. And that's why you notice that next to each of these genomics facility, we have always a green block, which is a laboratory of the National Health Laboratory Service. So as Francesco mentioned, both Richard and I, we are at CRISP at UKZN, but this week I also start a professorial position at University Stellenbosch, which what we are trying to do is now create multi-institutional organizations that can really respond to the epidemic. So if we go to the next slide, we're gonna see some very recent results that was produced by this network. So in the top graph, what we have here, it is again in the x-axis, the date of sample collection. In the y-axis is the number of genomes produced. Yeah. And so what we try to do normally is produce genomes that are associated in a representative way to the size of the wave. And these are random selected across the countries. So in the last week and a half, we have produced over 1,500 genomes, which really allow us to understand what had happened in the beginning of the third wave. And just to show you in another format and below, which may represent the same data as proportion of the genomes. Yeah. So if we start in the beginning of our pandemic around February last year, we have that gray shade. That gray shade, what it means is that normally we have 20, 30 different lineages circulating, and these were not variants that spread faster. And then what we have around like a middle end of last year was the emergence of a new variant with shaded in yellow. And this new variant we've initially named as the 501.V2, but then was recently renamed by the WHO to make easier for the general public as the beta variant. And this variant just emerged and then displaced all the other lineages. Why variants emerge and displace other lineages? Normally, when they are more transmissible and also associated with immune evasion, but we will bring information about that. Very recent, you're gonna see two different shades there. One is a blue shade, which emerged first, that's the alpha variant. That's the one that caused most of the infections in Europe and United States and the UK. It emerged but couldn't displace the other variants. And then very recent, and you may have heard our president last Sunday, yeah, we had this emergence of this green line, which is the Delta variant. And that variant not only emerged very quick, begin to take over and displace all the other variants. And it's gonna be clear why that happened during that presentation. So if we go to the next slide, now we're just gonna present the same data, yeah, in a different format, yeah. So this data now, what we have in the y-axis, it is the provinces of South Africa, and in the x-axis is the date of sample collection. So it's exactly the same data, but as you can see, for example, if you look here where we are in KwaZulu-Natal, we have the completely domination of what we call this yellow, what is the beta variant. And then we have the initial emergence of the Delta variant, and then it completely displays. And you're gonna see that the most recent samples, the great majority, it is Delta variant, but we will present in other formats. Unfortunately, the same happened in Gauteng, and I don't have to say how explosive the third wave is in Gauteng. So not that variant also emerge, it take over, and as you're gonna notice, it is probably the responsible for the very, very fast spread of the virus. We see the same in the Western Cape, in Limpopo and Eastern Cape, and now we are busy sampling the other provinces with recent data also showing domination in Mpumalanga. Unfortunately, we expect to happen what's happened with the Delta variant is that will completely take over the infections in the country. So if you go to the next slide, now we present similar data and add one other variable that it is in black line there, which is the 7-day rolling average cases. Yeah. So it becomes very clear from this graph that not only the number of average cases really going exponentially, yeah, and very, very, very fast. Yeah, as Francesco liked to describe sometime, it is enter a phase that like a rocket being launched and just really growing very high the numbers. Yeah, and then if you put that in perspective with the variant, it's begin to get a very clear picture that as the Delta variant start increasing prevalence in Gauteng, it is starting fueling the number of infections. Our last data in Gauteng that go around 19th of June, it pointed to over 75% of the infections or the genome sequence to be the Delta variant, and that's really closely associated with the growth of the epidemic. We see the same scenario in KwaZulu-Natal. To be honest, we found that much quicker in KwaZulu-Natal. So what we did, and that's what highlight us to highlight to our government that this variant was taking over, because the data in KwaZulu-Natal go until very recent. The most early sample is around 23, 24 of June. And then what we show is the same process, but just in the beginning of our third wave, which now very, very fast increase of prevalence of the Delta variant in green, being fueling the start of also an exponential growth phase of number of infections in KwaZulu-Natal. And so when I already start getting as data scientists, when we see like two provinces give the same results, we start thinking that this may be more widespread. Yeah. And so recent data from the Western Cape, which the last sample dates around 19th of June of this year, last genomes, unfortunately is painting the same figure, yeah, that they had the Beta variant, a few introductions of the Alpha variant, why potentially more introductions of variants of Europe in the Western Cape. They are quite well connected, tourism-like, yeah. But again, that cannot take over the blue one. And as the green line, the Delta variant start growing again, same process, and really in the beginning of the third wave. Yeah, so again, three provinces giving the same results. Some of the data of the other provinces are not as complete as the previous three, but will be completed in the next week. But the same profile, Eastern Cape, Limpopo, and Mpumalanga, showing quite similar profile, yeah, with some with better data than the other, but that is the numbers were stable with cases when the beta variant was dominated after the second wave, and as the Delta start growing, the cases starting shooting up, yeah. So if we go to the next slide, let's just try to bring some information about this variant, yeah. So how the scientific community classify the variants is looking especially at mutations. What are mutations? Mutations are amino acid changes that happen in the protein of the virus, and we can map them in two different ways. One is a linear way, as you can see in the mouse, and then what we mapping them linearly in the spike protein. So this variant has 6 mutations in addition to 1 deletions. Yeah. One question that come often, how similar is the mutations to the beta variant? Yeah. And the answer, yeah, they are very distinct. They only share 1 mutation, the 614G, but this one is shared by all the viruses in the world. But in reality, the mutations are very, very different. With some mutations, 2 mutations being the receptor binding domain, that's the most important part of the protein that will bind into the cell host. And if you get a look in the slide on the left there, we have the protein structure, and these mutations will be the top of the spike, yeah. And then other mutations will be substitutions at the N-terminal domain, a little bit down and in the right of the protein. And these ones are normally associated with antigenic supersite. What it means? That's regions that antibodies, natural antibodies of infections will affect the protein. But the mutation that the scientific community worried the most in that variant is the one at 681R. Why that? This is a mutation exactly in the furin cleavage site. And that's the part of the protein, that's going to be cleaved to make virions, to produce copies of itself. So what the evidence is growing is that this virus can produce much more copies of itself, which allow to be much more transmissible. But we're going to bring some of this evidence in the next slides. So if we can also map these mutations and compare them with what we call subclades of the Delta variant, and they get a little bit more complicated naming, but we're going to explain. The Delta variant is also known as the B.1.617.2. That was the majority of the genomes produced around the world, close to 100,000 genomes. And what we have here is the same figure that it's shaded in purple when the mutation is very high prevalent in that variant, And then you have two other sublineages or subclades of that variant that they got named as AY.1, and this is also common known as the Delta plus variant. Why is the Delta plus? Because as you're going to notice that it adds like one mutation at high prevalence. That's the 417N. That's why it's shaded in purple, and in the Delta variant, it's shaded in white. At the moment, this is not very widespread, but the scientific community is keeping an eye on that variant because it would make a little bit more immunogenic and potentially less effective for the vaccines, or potentially more for reinfection. But at the moment, very low prevalence. So as you show here, that the prevalence of that variant, the Delta plus, is 0.4% globally. In South Africa, we found only 3 genomes. So please don't, we are in a data breakfast, don't consider 0.7 higher than 0.4 because the sample size, I think that's one of the objectives of this breakfast. But in the United Kingdom, where it has been the most sampled country in the world, it's also at very low prevalence. And so far, these two lineages, the AY.1 and AY.2, which is known as a little bit the Delta plus, it is very rare around the world. If you go to the next slide, what happened with these variants? This variant first was sampled in India. Again, we don't know if it originated in India, but what we know is that it was amplified in India. What it means, that was the variant that caused that horrible wave of infections. And I think that many of you have seen the images on the TV. Was completely devastated to India. So because this variant, with not only it is more transmissible, but with the sheer number of infections that was created in India, it is got introduced everywhere in the world. And when you say it's basic, almost every country in the world that's doing genomic surveillance at a high level of recent samples have this variant. And in many of the countries, not only it was introduced, but rapidly became the dominant variant. For example, in the United Kingdom, now 90% of the infections are caused by the Delta variant. Unfortunately, the same seemed true in recent data of South Africa. In Africa, this variant is also spread in the Southern Africa, in the East Africa, Central Africa, and West Africa. And our laboratories are also helping a lot of the other African countries with data generation. So a lot of more data will come in the next few weeks. So in the next slide, just to put that in a global perspective, that what is happening in South Africa, what's happened in the UK is kind of almost what's happened around the world. This variant was at very low prevalence until Gosh, my eyes are not very good until May this year. Yeah. Thank you, Richard, for the very tiny slide. Yeah. And then it is as increasing frequency to almost displace all the other variant sample in the world. Yeah. Of course, that this may be biased to genomics coverage surveillance, such as country on the UK or South Africa that's doing good genomic surveillance. But at the moment, what we believe is that this variant, when enter a country, because high transmissibility will take over and displace the other variants and lineages. Yeah. So I will pass the presentation for our clinical ID specialist. Yeah, Richard Lessells is a real doctor, not like as me and Francesco. So he can give us more information about how that variant related to transmissibility, disease severity, reinfections, and vaccine. Thank you, Richard. Over to you.
Thanks, Tulio. So as we often say in these presentations, Tulio's kind of explained to you the picture and explained that we're moving into this new phase of the epidemic, not just in South Africa, but globally. And so what is always important is to understand what we're facing and to understand what do we know at the moment about this variant and what do we not know, where are there still gaps in our understanding. And this time around with the Delta variant is a little bit different from back in December and January when we were battling to understand the Beta variant. And really that was our responsibility then, because that was the variant first detected in South Africa. And we had the scientific capacity to kind of try and rapidly understand and understand the phenotype of that variant. So understand the behavior and the properties of the Beta variant. Now, as Tulio has shown you, this Delta variant has spread all around the world. And so the whole global scientific field is going to be working out the properties and the behavior of this Delta variant. And so we're already getting a good understanding of some of this just because it's spread so rapidly and there's so much science going on around the world. So this really just summarizes the kind of main points that we want to discuss, and then we're just going to walk through each of these in turn and just explain them a bit more. So just to summarize, the key feature of this Delta variant is its high transmissibility. So this is now a highly transmissible virus, and there's good evidence that it's more transmissible than all the other variants that we've seen as of yet. In terms of whether this Delta variant causes more severe disease, we don't yet know. And I'll explain to you why, although that's an important question, it becomes a somewhat academic question at the moment when you've got such a highly transmissible virus causing a huge number of infections over a short space of time. One of the things we worried about with the Beta variant, you'll remember, was because of its properties of immune evasion, we worried that it might be able to reinfect people that had been infected before the Beta variant came along. And we're not sure with this Delta variant whether there might also be a risk that that could reinfect people who were infected previously with the Beta variant. And we'll just touch on some of the data that kind of starts to give us an understanding of that, although that's a very difficult area to understand. And then often the most important question for us, especially in this phase of the epidemic, is what does this variant mean for the vaccines? And there the news is encouraging. And there's kind of new data coming out again on a daily basis. And that data is now showing us that the vaccines should retain high levels of protection against severe disease with this Delta variant. So just to walk through each of these and explain in a little bit more detail. So in terms of transmissibility, and remember, by transmissibility, we just mean how efficiently this virus spreads from person to person. And what we can see from data from a number of different studies suggests that the Delta variant is significantly more transmissible than the other variants of concern. And by that, we mean the Beta variant that was first detected here, the Alpha variant that was first detected in the UK and then spread throughout Europe and North America. And it's probably somewhere in the region of 30 to 60% more transmissible than these other variants of concern. And you'll remember that those variants of concern were more transmissible than the original viruses that started this pandemic. And so where we are now is that this Delta variant is probably somewhere around twice as transmissible as the earliest viruses. Now, that's significant because this was already a highly transmissible respiratory virus. But now we're dealing with something that's extremely transmissible. And that's why we're seeing this rapid rise in cases in Gauteng and starting to see in other provinces, because this virus spreads very efficiently from person to person. And that means that it can spread very quickly in our communities. It can spread quickly within healthcare facilities and within other institutions and anywhere where people are gathering in close contact. So what this means is that it becomes much more difficult for us to control. If you think back to that first slide that Tulio showed you, when we talked about the basic reproduction number, or there we were showing the what's called the effective reproduction number. But you'll remember from early talks in the data at breakfast, we talked a lot about the reproduction number as it gives you a sense of how transmissible a virus or a pathogen is. And we knew that the original viruses that came out of China had a reproduction number maybe somewhere between 3 and 4. So that means on average, one person can infect 3 or 4 other people. And that's how the virus spreads through a population. If this virus now is twice as transmissible, that implies that on average, this virus may be able to, one person may be able to infect 6 or 8 other people. So that gives you a sense of what we mean when we're saying this is twice as transmissible as the original virus, and just gets us into the space where we're dealing with a highly transmissible virus. One of the things that has been noted in places where this Delta variant kind of reached quite early on and has already become dominant, such as the United Kingdom, is that they may be seeing a slightly different symptom profile. They have this very impressive kind of symptom app in the UK that monitors millions of people's symptoms and gets a sense of the epidemic from that kind of electronic symptom monitoring. And one of the things that's picked up is that the profile of symptoms seems to be more what we call coryzal symptoms, and by that we mean the kind of symptoms of the common cold. So kind of more runny nose, sneezing, headache, sore throat. And some of the symptoms, some of the slightly odd symptoms that we highlighted previously, like the loss of taste, the loss of smell, these seem to be less prominent. early reports from South Africa suggest, from clinicians, from private GPs, from clinicians on the front line, suggests that they're also seeing a similar picture. I think there is more work needed to understand if this is something to do with the variant itself, or whether it's reflecting that this variant is initially infecting younger people or different population groups, whether it's in some places because it's infecting people that have had 1 or 2 doses of vaccines, or whether there's a change in the kind of testing practices in some places. But it seems, as we gather more data, that this is a pretty consistent finding, and we'll see how consistent it is in South Africa. The key thing here from a public health perspective is that we need to understand this so that people are testing and are self-isolating when they have any symptoms suggestive of a cold, of the flu, of COVID. Our symptom kind of profile for testing in South Africa is still quite restrictive. It's still based on just a few symptoms, and it doesn't necessarily include the runny nose, the sneezing, the headache. And so we need to get back and consider that kind of symptom profile, but also just highlight to people the importance not going to work if you've got any of these symptoms, however mild you may think they be, and however convinced you are it's just the cold. These need to be taken seriously now. In terms of the kind of profile of severe disease, so people that end up in hospital, is there a different clinical profile there? There's no evidence to suggest that yet. And again, we'll be gathering data here in South Africa to compare with many other places. But there's nothing kind of jumping out from the data anywhere in the world to suggest that the disease is different once it gets to that severe stage. And in terms of whether it leads to more severe disease, so is there an increased risk of getting to that severe stage and of dying from infection, we don't know yet. There's some preliminary data from the United Kingdom suggesting that there may be an increased risk of hospitalization in the couple of weeks after a positive test. And because of their genomic surveillance program, they are able to compare the Delta variant to the Alpha variant, and they can show that the risk is approximately double with the Delta variant. But this is early evidence from the kind of as the Delta variant was taking over and becoming dominant, and we have to see whether that relationship is maintained and whether we see that in other places around the world. There's no evidence currently of increased mortality, but we need much more data on that. And it gets complicated to analyze that data now in different parts of the world, because you're getting predominantly younger, unvaccinated populations affected with this Delta variant in many parts of the world where vaccination coverage is much higher than South Africa. So again, this will be something that we'll be following closely here in South Africa. And some of the kind of research capacity that was built up as we were trying to understand the Beta variant, some of that kind of scientific capacity will now be kind of used to try and understand the Delta variant in our context. People are always worried when we talk about these mutations and variants, whether this affects the tests that we use to detect the virus. And we use two different types of tests. We use what are called the PCR tests, and we also use kind of rapid antigen tests. So the PCR detects the genetic material, the antigen test detects the protein. And so far, there's nothing coming out suggesting that the mutations in the Delta variant affect the performance of the tests, either the PCR or the rapid antigen tests. So when you go for testing, these tests should be able to detect the virus. Now, here we're getting to thinking about how well the antibodies from previous infection, how well these antibodies neutralize the virus in the laboratory. So you'll remember we talked about this a lot when we discovered the beta variant, and it was one of the most kind of early prominent findings around the beta variant was that the serum collected from people infected in the first wave did not neutralize well the beta variant. So the beta variant was resistant to neutralization. And that was what gave us concern initially about the beta variant being able to reinfect people, and also that it might affect the vaccines. So here we're looking at what do we know about the Delta variant now on the same point. And here on the top graph, what you're looking at is a study from a group in Oxford, in the United Kingdom. And here they're looking at the 4 variants of concern. So here you've got alpha, beta, gamma, delta. And this thing labeled Victoria is essentially one of the very early viruses before any of these variants of concern emerged. So kind of what we call the ancestral virus. And what this is doing is taking serum which contains antibodies, neutralizing antibodies from people that were infected early in the epidemic, and it's seeing how well it neutralizes each of these variants. And what we're trying to show here is that you can see, compared to the original virus, there's some reduction in neutralization for all of the variants of concern, but it's most marked for the beta variant. The drop in neutralization is most pronounced for the beta variant. And when you look at this Delta variant, it's not as pronounced as the beta, and it's more in line with the alpha and the gamma. So some reduction, but not as marked as what we were seeing with beta. Now, the next thing is at the bottom. Here we're looking at exactly the same thing, the 4 variants of concern and the original ancestral virus. But here we're taking serum from people who had been infected with the beta variant. And we're seeing how well that neutralizes these different variants. You'll remember, again, some of the science that came out of South Africa from Penny Moore's group, from Alex Segal's group. You'll remember that we said the serum from people infected with beta at that time seemed to neutralize other variants very well. So it seemed to be kind of what we called cross-protective. And we could show that it neutralized the alpha variant quite well and other viruses. But what you see here is with the Delta variant, this serum collected from after beta infection does not neutralize so well. So there's a big drop-off in the neutralization. And this comes back to the point that Tulio made, that these variants are quite distinct. The mutations are very different in the Delta and the beta variant. And so it may be that the antibodies that are generated when you're infected with beta don't recognize so well now the Delta variant. So this is laboratory data. it's early data, and we need to see more experiments like this. And we also need to do these experiments here. And as you probably expect, as I said, Penny Moore's lab at the NICD, Alex Segal's lab here in Durban are already busy working on these similar experiments to try and understand this in our context. The point here is that this raises some concern that people who were infected with beta, so people that were infected in South Africa in the second wave, they could still be susceptible to reinfection with Delta. And really that's for us the key public health message again, is that everybody still should consider themselves susceptible to being infected, whether they've been infected previously or not, and whether that prior infection was in the first wave, the second wave, or whenever, everybody should still consider themselves susceptible and should act accordingly. And also, people should go for vaccination when it's their turn, again, regardless of whether they've had a prior infection or not. Now, the next question is, how well do the vaccines neutralize this Delta variant? And here we're showing you again, very similar laboratory data. This is from the same study, but instead of taking serum from people who had been infected, they're taking serum from people who've received either the Pfizer vaccine or the AstraZeneca vaccine. And you're seeing exactly the same thing with the 4 variants of concern. And again, here what you're seeing is there's some drop-off in neutralization for the Delta variant, but for both of these vaccines, it's less than for the Beta variant. So essentially what we're showing you here is that the Delta variant does have some resistance to neutralization, but it's consistently less than what we've seen for the Beta variant. And that tells us, or gives us a sense, that we expect the vaccines to work better against the Delta variant than against the Beta variant. I had there that neutralization data for Johnson & Johnson vaccine is pending. Actually, it came overnight. And again, like all these talks, you have to keep up on an hour-by-hour basis as to the science that's being churned out. And by the time you give a talk, it's already out of date, and you've probably missed some information. But this came out through the night, last night, a preprint from the Johnson & Johnson group, or the Janssen group, looking at how well the serum collected from people after receiving the Johnson & Johnson vaccine, how well that neutralizes the Delta variant. So you can see slightly differently from the previous figures, but here we're seeing the Beta variant here, the B.1.351, and here's the Delta variant, which is the B.1.617.2. And this is kind of the earlier viruses that we kind of saw in the first wave here in South Africa and elsewhere in the world. And really, it's just showing you again consistent findings that although there's some reduction in neutralization, it's pretty minimal compared to these viruses, and it's not as marked as the Beta variant. So consistent data from all these different vaccines, and suggests to us that we'll see the same kind of pattern of how this translates to how well the vaccines protect. So one of the key things, as we've said, is this Delta variant spreading around the world, and many of the places where it's spreading and becoming dominant are able to produce science very rapidly to inform public health. And here is data from the UK, where they are able to kind of continuously monitor the effectiveness of the vaccines as they roll out their vaccines through the population. And also, as Tulio mentioned, because they have very high coverage in their genomic surveillance, they can actually look continuously at the effectiveness of the vaccines against specific variants. So here, what we're looking at is the two vaccines used in the UK, the AstraZeneca and the Pfizer vaccine. And we're looking at estimates of effectiveness of these vaccines, either after the first dose or after the full 2-dose schedule. And then we're comparing the Delta variant to the Alpha variant. And what we're looking at here is data looking at protection against hospitalization. So we're looking at the more severe end of the disease spectrum. And what this is showing you is that with this Delta variant, there are high levels of protection against hospitalization, even after the first dose. So over 70% protection against severe disease requiring hospitalization. If you look after 2 doses, that then goes up to over 90% for both of these vaccines. And really, there's no difference when you look at the Delta variant to the Alpha variant. So very encouraging data from the UK to show very high levels of protection against hospitalization. And that's the key thing that we're trying to do with vaccines, and especially the key here in South Africa is we're trying to prevent that severe disease that requires hospitalization, try and reduce the pressure on our hospitals and our healthcare facilities. When you look more broadly at kind of not just the severe cases requiring hospitalization, but all cases of COVID. What you see here, if we start from the right this time, we show still good levels of protection after the full 2-dose schedule. But you see some drop-off in the protection just after the first dose. So compared to the Alpha variant, this slight reduction in the effectiveness of the vaccines after the first dose. And so what this is just showing is, in terms of protecting against all forms of disease, it's critical that when we're using a 2-dose vaccine like the Pfizer, it's critical that everybody gets the full 2-dose schedule so that they're fully protected against clinical disease. So just to summarize, and then I hope we've got some time to take some questions. Tulio has shown you convincingly that the Delta variant is now rapidly becoming the dominant variant globally, and South Africa has not escaped what we're seeing around the world, and it now seems that this has become dominant already and has essentially displaced the previous variant of concern, the Beta variant. We now have very clear evidence that Delta is a highly transmissible variant and more transmissible than anything we've seen as of yet. We've looked at some laboratory neutralization data, which suggests to us that there may be some reduction in neutralization in people who have had prior Beta infection. And so one of the things we'll be looking out closely for in our kind of clinical research field will be understanding to what extent people are getting reinfected with this variant and how that contributes to the spread of the virus in the population. And then in terms of the vaccines, again, although in the laboratory there's some reduction in neutralization, we have good and convincing effectiveness data that suggests that the vaccines retain good protection against severe disease with this Delta variant. So I will stop there and hand back to Francesco to hopefully coordinate some questions.
Yeah, thank you very much, Richard and Tulio, for this really fantastic update on the current COVID situation in South Africa and globally. I see we have lots of questions in the Q&A, and two participants raised their hand very early on in your presentation. So maybe I will ask Ilya maybe to give the two participants, Rebecca and Bilkish, maybe the right to ask their question in person. And after that, we will go through the questions in the Q&A. So maybe if Rebecca would like to start with her first question. Rebecca, I think you will have to unmute yourself. You have the right to speak. Let me see. Okay, I'm not sure. Please, Rebecca.
Hello, good morning. Thank you so much for the wonderful presentations. Yeah, I was just very curious, but I guess Richard has answered most of my questions as he went through. But anyway, I'll go ahead and ask just for the benefit of everyone else who's asking, who's listening as well. So I was just very curious about how the virulence and the fitness of the Delta variant compared to the other previous variants. It would appear that it might be, it's displacing all of the others. So I'm just wondering if it has gotten fitter, it's more virulent compared to the other ones. And also I had asked a question about the severity of disease in comparison to the predecessor variants. Thank you.
Thank you.
I can start answer the first, and then I pass to Richard. Yeah. Rebecca, so what we know about this variant, is more transmissible. So that's quite clear. And that's the main reason why it is displacing the other lineages and variants. That's the current knowledge of the scientific field. In relationship to virulent, I would just pass to Richard, but my main comment is that doesn't seem to be more virulent, but we also really worry what happened in Gauteng. If the sheer number of infections with no difference in virulence present all at the same time in a hospital, it completely overwhelmed the hospital. But Richard, you can comment further.
No, I think that's the key point. Really, is that whether it's whether the virulence or the pathogenicity of the variant is different becomes somewhat academic when it's so much more transmissible, as we've seen, because as Tulio says, that transmissibility trumps everything. It leads to such a high kind of intensity of transmission, and that translates to a kind of intense pressure on the health system that then affects the clinical outcomes and affects the kind of level of mortality. So the transmissibility leads to poorer outcomes across the population. I think the reality is the severity question is a very difficult one to answer. We know that even for the beta variant, we still don't really understand whether the beta variant was associated with more severe clinical disease and increased mortality compared to the earlier viruses. We've done various studies in South Africa to look at that, but it's a very difficult question to tease out. Even in the UK, when they were trying to understand was the alpha variant associated with more severe disease, there's still some question about that. There is some findings that suggest it is, but also some conflicting findings. So the reality is scientifically, it's a difficult question to answer. And I think it's more difficult now because we've got vaccines rolling out, because in many parts of the world, this Delta variant predominantly affecting younger unvaccinated populations. So looking at the mortality and the clinical severity is going to be even more complicated. And my guess is we won't get a good sense of whether it truly is more virulent or not. And as I say, and as Tulio says, it kind of academic because of the high transmissibility.
Thank you. Thank you very much. And now maybe we can ask Bilkish Kasim to ask the question. Thank you.
Good morning, sorry, my hand was raised in error, but I will take the opportunity of thanking both Tulio and Richard for an excellent presentation.
Thank you, Bilkish.
Thank you.
Yeah, thank you. That was a very easy question. Thank you.
Are representative participants that express the gratitude for all participants. There is one more very interesting question by Martin Bucher. And please, Martin, if you would like to ask your question.
Okay, first, thanks to both of you for really excellent talks. My question is to Richard and pertains to the slides with the neutralization data. So one of the striking things in those slides was there's this y-axis labeled dilution, and then for each of the variants, I mean, for the same variant, there's a huge spread by several orders of magnitude, and I guess the response and that's seems much greater almost than, you know, the variation between the different variants. Could you maybe tell us a little more about how to interpret those slides? You know, what dilution factor represents an effective response, or how should we interpret that?
So I mean, you're quite right. I mean, you're also making the point there's a small number of data points. I mean, us kind of researchers who do clinical research and population research always kind of look at lab research and with envy, because they can present science where they have kind of eight or nine data points, and so there's often this kind of sense that that's a very small sample size. But really, with these lab studies, it comes from the kind of consistency of the data. So what you'll get is we kind of showed you one study to be kind of representative, but actually there's already kind of 5, 6, 7 different studies all looking at the same thing. So although there's small sample size, it's kind of consistency of findings. I think your point is a very important one, that we know that the immune response to this virus is highly variable. So we know that everybody doesn't have the same immune response to the virus, whether it's a variant of concern or not a variant. The level of antibodies that you produce and how quickly those antibodies wane is quite variable. And so that's what's reflecting in those slides, is that kind of inter-individual variability. And as you say, what's also important is the kind of magnitude of the neutralization. So you've got the kind of, you're looking at not just the relative drop in neutralization, but what the absolute level is. The problem is we don't know for sure what is the level of neutralization required to protect someone, either in terms of whether they've had a prior infection or with the vaccines. We're starting to get an understanding of that now as to what level of neutralization is a protective level. So I'm not sure if that's answered your question, Martin, but it's kind of, yes, there's a lot of variability. And so although there are a small number of data points, it's looking at all these different studies and the consistency of the findings. I think Tulio will add a bit to that.
Yeah. And just to add, Martin, yeah, one of the things that you see in that graphics, there is a line connecting the dots. Yeah. So what they are really doing, they are taking the same serum from the same individual and then expose the different variants, and that's what make consistent, and that's why you have the lining relating to all of them. And some individuals will generate more antibodies than others, and that's why you see the difference on the y-axis. But what we see is this consistency, that people that generated high antibodies tend to generate high antibodies against the other variant, and so on. Yeah.
So you wouldn't be able to guess where to put a horizontal band or line, what is enough, what is insufficient? I mean, that of course would be the thing that one would really love to know if one could.
So we're starting to get that information. So actually, says, I mean, there's a preprint from the Oxford vaccine group this week where they've tried to do that for the Oxford AstraZeneca vaccine. So based on their clinical trial data, they've tried to estimate what is the level of antibodies that is protective. So we will start to see that data come out. What is also consistent, and I think we didn't highlight on the slides, but you kind of see it consistently. We know that the mRNA vaccines, so like the Pfizer, but also the Moderna, they generate much higher levels of neutralizing antibodies than some of the other vaccines, like the AstraZeneca, the Johnson & Johnson vaccines that are a different technology. So although you see the same kind of relative drop-off with these variants, the Delta and the Beta, your starting point for the mRNA vaccines tends to be much higher. So although it may be the same relative drop-off, you're still getting a higher level of neutralization, and so that's just understanding kind of some of the differences. But again, that's in the laboratory, and so translating that to what that means in the real world situation with vaccination is more complicated, and what you see with the vaccine effectiveness data is that actually the protection is high for the different types of vaccines, the Pfizer, the AstraZeneca, and we know from South Africa quite high levels of protection for the Johnson & Johnson vaccine, even against the Beta variant.
Thank you, Richard.
And the other point just that we should always highlight is we're looking at one part of the immune system when we look at neutralization data in the laboratory. We don't look at what's called T-cell activity, because it's much more complicated to do and it takes much more time. But what we understand is that the T-cell immunity is much less affected by all these different variants. And we have to learn about that for the Delta variant as well. But that has a big part in understanding how well the vaccines will work.
Thank you, Richard. Maybe one last question by Amanda Veltman. Please, Amanda, if you would like to ask your question.
Hi, thanks for that great set of slides and talk. It really helps to have a slightly more nuanced view than what's presented in the general fora of the government. I just wanted to ask, I know that you only got the paper last night, but I'm wondering if there's equivalent numbers for J&J, for the J&J vaccine in terms of effectiveness, both for asymptomatic, for symptomatic disease and hospitalization, the same as you had for Pfizer and AstraZeneca. And if those numbers, if those numbers exist, like you can just tell them, or if they don't exist, based on what you just said, should we assume that J&J is comparable to a single AstraZeneca because they're of similar type, or is it impossible to compare the single to the double dose?
Yeah, good question, and it is one of the key questions, and a lot of people are asking the same question. I think the problem is the Johnson & Johnson vaccine is not used in all that many places. So actually, in South Africa, we're one of the few places using it alongside the United States. What we were seeing was data from the UK, and that was based on the two vaccines they are using in their program. We are going to get some effectiveness data here in South Africa from the Sisonke program initially, and then potentially from other work within the kind of national rollout. The challenge for us is that although we've shown you all this genomic surveillance data, we don't do genome sequencing on every case of COVID. We do we sequence roughly 1 in every 200 cases. So we have relatively low proportion of genomic sequencing. So that makes it quite difficult with something like the Sisonke program to actually look at the effectiveness against the different variants, because this Sisonke program has been running during this period of time when initially the beta was still dominant, and then the delta has kind of taken over. So it's going to be quite difficult to unpick the data there to understand the effectiveness. So I think what we end up with is, like you say, is putting all the data together and kind of extrapolating to some extent from the laboratory data and from what we know from the clinical trials of how the Johnson & Johnson worked against the beta variant. And we say, because against the beta variant, it had high levels of protection against severe disease. And because we know in the laboratory, the Delta variant is less resistant to neutralization than the beta, we fully expect the Johnson & Johnson, after the single dose Johnson & Johnson, we expect high levels of protection against severe disease. So that's the expectation. It will be nice to see some real data, and there is data going to come out from Sisonke, and there may be other data that comes out from the United States. So we just need to wait a bit. But the key thing is that people offered the Johnson & Johnson vaccine should absolutely take it. That's the vaccine I've had, and I'm very confident that I've got good protection against this variant.
Yeah, thank you very much, Richard. I know there are still some questions open, but I have the feeling that Richard and Tulio answered more or less implicitly in the talk or during the Q&A questions. I'm just worried about the time, and you see Tulio, Professor de Oliveira had already to leave us for other commitments, and I'm sure that Dr. Lessells is also does also have to run to other serious commitments for the day and for helping us fight this pandemic. So I would like to thank, of course, in particular, Tulio and Richard for taking time out of their very hectic schedule and all their responsibilities. So thank you very much to both of you, and I will make sure to thank Tulio separately later when he has again a second. Thank you also to all the participants for being with us again early this morning. And yeah, and as Richard said, please, if you have the opportunity to get a vaccine, get the one that you can get on offer in South Africa, and please do register and make sure that that you get it quickly. Yeah, so thank you very much. Have a good day, and please stay all safe. Richard, thank you very much for your time and for the fantastic presentation. Thank you.
Thank you. Stay safe, everyone.
Yeah, thank you. Bye.